overview. I'll do a quick overview of what we're going to be doing today, then we'll run through our normal roll call, um, director updates. We're going to talk through the bylaw changes and move for a vote for approval. And then Kim Hankins from this Naloxone State Purchasing Group, MMCCAP, is here to facilitate a conversation around naloxone purchasing. And then we'll close with public comment. I think we can move towards doing roll call. Ashley, would you like to start that?
Good morning, everybody. We're going to run through the list. So if you're present, please just say that you are here. Dharma? Blue? Blue Valentine? Mariah? Eric?
I'm here.
Haven?
Good morning.
Good morning. Naomi? Naomi might be here in a little bit. All right. Jenna?
Here.
Great. Adam?
Here.
Scott?
I'm here. Good morning.
Good morning. Serafina?
Here. Good morning.
Good morning. And Crescencia?
Here.
And I don't think I missed anybody. We have a couple late joiners, but we haven't quite met quorum yet, Stacy. So we can know.
I think Blue just came in.
Great. Blue?
Here.
Perfect.
Hey, Blue. Okay, great. I think we're there.
Mhm.
Awesome.
Just kidding.
Okay, great. I'm going to ping us right over to Annalise for director updates.
Thanks, Stacy. Annalise Dolph, Director of the Alcohol and Drug Policy Commission. I'm going to kick us off with kind of my usual round robin of other stuff happening, but then turn it over to Mara and Stacy to talk about SAMHSA's latest letter to us. We all thought we wanted to know what was in our drug supply, but apparently not with test strips. So real quick, though, on updates, the commission met earlier this month to go over our first quarterly update on the plan. So that was exciting. If you want to try and track at the full plan level what's happening, that was exciting to bring that forward. Next month, we are going to talk as a full commission about the plan and how we take what we've put together for a recovery-oriented system of care and give more program level guidance. We're getting a lot of requests from different agencies with different funding streams about what it means to align with the plan that you all put together. So we're going to be talking a little bit more about that. The recovery committee is talking about recovery community centers. They put together some kind of a definition of recovery centers. There's going to be a summit at Peerpocalypse this weekend with current recovery center providers to talk about that. The recovery committee is also working with OYA to talk about recovery spaces. Folks will remember that that was something that was important to the Youth Addiction Alliance to really define what it would mean to have a recovery space within other spaces, in addition to maybe like a youth recovery center. So they are talking about those definitions. Treatment is going to start talking about provider surveys and landscape assessments on their work. And prevention continues to talk about House Bill 3321, the primary prevention assessment, and the concept that they put in the plan of a kind of center of excellence, if you will, some kind of TA center for upstream primary prevention. So those are the high level updates from the director. we had a reach out from a couple folks about the Dear Colleague letters that came out on Friday. There was one related to medications for opioid use disorder. And I know Mitch is here if folks have some questions about what we're thinking about how we're going to, what that means for MOUD. But most importantly to this committee, we did want to talk about the Dear Colleague letter that related to injury prevention and harm reduction supplies. So I'll turn it back over to you, Mara and Stacy, to take this.
Great, thank you. Thank you, Annalise. Mara, did you want me to start or would you like to?
No, go ahead. If you go ahead. I put these in the slides, so it should be pretty easy to walk through.
Okay, thanks. Mara captured the biggest changes and concerns related to this group in the slides. And so the biggest piece that we're looking at here is the determination, or I feel like they've said this before, but more specifically that no federal funding can be used to purchase safer smoking kits or other harm reduction supplies that, as they state, promote or facilitate substance use. So that's the biggest piece. In addition to that, the sterile water, saline, or vitamin C, if it's used to, quote, facilitate substance use, drug use. So that was the biggest takeaway from this slide, from this part of the letter. And I'm not sure what's on the next one. Okay, another way to look at it.
Yeah, well, wait, Stacy, I'm gonna jump in here. So I think maybe this was a little bit confusing. So in July of last year, this Dear Colleague letter came out that basically said, here we're going to clarify what SAMHSA federal funding can be used for. And the previous slide was what from the July letter, what could not be used, what federal funding could not be used for. This is what federal funding could be used for, according to the July letter. And then the biggest change in this updated Dear Colleague letter is on the next slide that I have highlighted. If you can go, Ashley. Thank you. Which is the change in fentanyl test strips, in being able to spend federal funding on fentanyl and xylazine and medetomidine, all of the test strips. So this was something that was brought to our attention. We have been following this, but it was also many of you came to us and said, like, hey, can we talk about this? So I think this is what we wanted to bring up, is the biggest change here is like the explicit mention, the explicit switch up of saying it used to be okay to use federal funding for test strips, and now it is not.
Yeah, thanks for jumping in. I was making that more confusing by bringing us back a year ago. And I think the other piece is that the ADPC does not receive federal funding directly, but OHA does. And so we're impacted in that way. Go ahead, Haven.
I also do want to highlight, though, that a big difference between the July letter and the current letter is in the July letter, it was explicit that you could not use federal funds to purchase these items. Whereas in the current letter that came out, you cannot use these funds to purchase or distribute these items. So the difference there in the way I'm reading it, not a lawyer, is that like we could use federal funds to pay staff, for example, and use some of that for staffing for programs, which the way I'm currently reading this letter, we can no longer do that. So like if I have a staff who is partially federally funded, I can't have them jump in the syringe exchange to help cover because then they are distributing supplies under these funds. I also think a big thing with this letter, and part of why I brought it up and wanted us to be considering it, is that the previous letter only referenced SAMHSA funding, whereas this current letter brings up all of HHS funding, which is different. And it doesn't necessarily mean that other federal agencies are going to follow these guidances, but they did in the July letter. So I think we need to be thinking through like how this would impact, for example, FQHCs who may be distributing fentanyl test strips or safer use supplies, because if they're doing that under HRSA funding, they could be violating their contracts. And like, I really, again, I'm not a lawyer, I'm not sure, but the way I read this really does have me concerned about people not really understanding that they are violating federal funding laws by doing something that has been so common for us to do. So like, even if they're getting their test strips through the clearinghouse, not buying them, if there's using federally funded staff to distribute them, that may be in violation.
Thanks, Haven. I'm thinking. That's my thinking silence. I just want to direct, there's some great content and like comments in the chat. And then Mara also put a comment about a footnote about where the prohibition does not apply to. Annalise, what is our process for like getting an interpretation from OHA on the next steps? Do we have a process for that?
Yes. So I was just putting in the chat. Unfortunately, Jude couldn't be with us today. Anne Chakman in Public Health, thank you. Anna is sharing some information in the chat. To Anne's point, there is explicit language in the Support Act about funding for test strips. So OHA Behavioral Health has already let us know that they're going to be seeking clarification from SAMHSA on that. So I think if there's other questions for OHA, what we would like to do is kind of take those in. I hear, Haven, what you're saying, and we had talked previously also as a committee about maybe having some folks who are attorneys come and not give legal advice, but maybe talk about the state of the law. So that's another thing that we can talk about. One thing I do want to point out to folks, and if you have some information that we haven't heard from BHD about this funding, I think Public Health is not funding test strips. If there's some other funding, it'd be great to hear from you. I will reiterate to folks that this, yes, it applies to SAMHSA funding. It also seems to apply to HHS funding, so we'll see what happens with that. This does not have any binding whatsoever on opioid settlement funding, which I will remind folks is the primary funder of Safe Lives Oregon. So that's something to keep in mind.
That clarification is helpful. So with the options that Annalise provided, do any of those sound like interesting to you, Haven, in terms of having someone come and talk with us a little bit more about the legal pieces, not give legal advice, but the interpretations?
I mean, I'm a nerd who likes to know all the things, so I'm always willing to listen to people who know more than me. I also think there's more questions than answers, like the way this rolled out. I was on a call yesterday with some national folks talking about it, and like, it sounds like it came out from the very top, and even like grant organizers and like people distributing these funds learned about it at 4:45 on Friday. So maybe by next month there will be more clarity, but I think we need to be thinking through how we support organization. Like, I'm old enough to remember how to operate under the federal funding ban and how to like do my job while it's federally not all that legal. Whereas a lot of programs are newer to this work, may not have that experience to be able to navigate that. And I would like to help folks do that if we can.
Yeah, that's great. So it sounds like maybe I'm just like thinking through what the next steps could be. And a potential next step is just to keep this as an agenda item for the foreseeable future, so that we can have just an ongoing conversation, even if it's just 5 or 10 minutes at each meeting, longer if there's something decision making, or someone to bring in to have a conversation with us, as we get more information. So we just have a placeholder to be able to discuss it and plan. Does that sound reasonable to the group for now? Okay, Mara, is that okay with you if we just put a placeholder? Okay, cool. That's great. And thank you for jumping in. I was getting confused with the slides. Sorry. Okay. Um, Before we move on, let's just make sure there are any other pieces related to this guidance that we want to discuss before diving into bylaws. I want to make sure that I captured everything from the chat as well, just really quickly. Okay. And thank you for putting the links in there. That's helpful. Thank you. Oh, Blue, I'm so sorry. I didn't see your hand. Go ahead. I apologize.
That's okay. I think I heard Annalise mention that, but I'm assuming that maybe some of the other subcommittees, especially treatment, are going to be responding and maybe working on that guidance. Is that correct? There was some new guidance around medication for treatment.
Oh, the MOUD part. Yeah, got it. Go ahead, Annalise.
Yeah, and I think Mitch is here. Mitch, if you want to hop in, there are pieces of it that I think Mitch has done a better job at silver lining it for us. It makes it clear that folks that don't get on medication and they don't stay on forever and they need accompanying treatment, we think it might maybe even help pave the pathway with some of our youth providers who have been very hesitant to prescribe MOUD. I think we're concerned about, as you can imagine, that insurers will take this as a sign to start to bring back prior authorization or bring back some caps that we've succeeded in getting rid of. So we'll be closely tracking those claims as we move forward to see if it has a deterrent effect on MOUD.
Yeah, I can hop in just really quick. I'm commonly referred to as our team's like bleeding heart optimist, sometimes to a fault. And so just know that that's where the silver lining's coming from. But timely thing is we're about to launch, and I'll put a link to our form in the chat as well. We're about to launch some of our work groups underneath the treatment committee, and this is one of those areas that I think we can be really supportive. For those of you that have been in the treatment system for some time, we used to have a thing in opioid treatment programs called methadone maintenance therapy and medically supervised withdrawal, where we were doing these checks on 90-day, 6-month, and 1-year cycles anyway. So this is, I think, kind of similar to what you had said, Haven, like sort of a return to form for a lot of folks. And so I think some of this is going to be sheltering individuals back to a time where, yes, we had these burdensome checks and balances there, but also I think this is happening at the exact same time that ASAM 4 is being implemented, and so we can really root these in what we know about medical necessity and make sure that this is not an undue burden to our providers, but making sure that this is actually something that's built into treatment planning and service planning and all of those things. So I'm already working with the SOTA team to make sure that we are like addressing this early and as clearly and as concisely as possible. So I'll drop the interest link to our work groups if anybody wants to be involved in that work. I'm not sure like when we'll touch it, but it is something that is very close to my mind and I've already been working on. So
Thanks, Mitch. And I guess I'm also thinking from like the payer perspective, I'll circle back with my colleagues at Care Oregon just to make sure that they are aware and we're tracking from the very beginning, from that standpoint. Okay. Any other questions? I'm not always seeing the hand, so just doing a quick review. I don't see any other hands up. Okay. And again, the letter is in the, thank you, Anne. It's in the the MOUD letter is also in our chat for those who want to look. And Blue, it sounds like that answered your question for now. Okay, great. Do folks feel okay about transitioning to the next, to the bylaws? Happy to give this a little more time if we want to continue to have a conversation. We can, and okay, then Mitch put the form in the chat. Thanks so much, Mitch. Then we'll just make sure that this is a standing, both of these pieces are standing items going forward. Mitch, maybe you can let us know if you want to give like an update, a more specific update, like, okay, next month. That would be great. Okay. Thank you, everybody. That was really helpful conversation and information sharing. I think we can move on to our bylaws conversation. So just as a reminder, we're going to be moving towards a vote, hopefully today. So here is a reminder of what was changed, and then I will turn it over to Mara to go more into depth about the changes to introduce the edited language. So the bylaws shifts include adding a co-chair. So if you are interested in co-chairing with me, love to have you. Just let us know. You don't have to you don't have to say yes right now. Just think about it and send an email to any of us. Could be really fun. And we can answer any questions. Another change was aligning language with the full commission around attendance. So trying to get folks here more frequently on a regular basis. So specifically it'll say that missing 2 meetings that are unexcused, we can remove from a voting slot. Of course, you can still attend as a public member. The name was changed throughout the document to health and safety. And then the removal of the intro paragraph with questionable links. And I think that's the changes. Mard, are you ready to take? Okay, great.
Yes.
Thanks so much.
So those were the changes that last time when we talked, just a reminder, just to reiterate what Stacy just said, that that when we talked, these were the things that we had all agreed upon. And the only thing that we were going to talk about this time and put to a vote for the entirety was the change in language in the first paragraph. So if you'll recall, we talked about scope of the ADPC and our committees. And we mentioned that potentially some language in the first paragraph, which mentions social justice, is not within our scope. So we wanted to change some of the language in that first paragraph to make sure that it fits within the scope of what our committee is supposed to do. So there was some discussion of that in person, and then I'm sorry, when I say in person, I mean like during the meeting out loud. And then there was also some discussions in the chat. So if you could actually go to the next, and I know this is a lot. I will just bring your attention to the highlighted portion, which is what was the suggested language, which says the Health and Safety Committee operates on a shared belief that respecting the rights of people who use drugs is critical to providing the best services to those that access them. And what that does is that replaces the line, where is it? Harm reduction is a movement for social justice built on a belief and respect for the rights of people who use drugs. We moved some things around and took out the phrase social justice. So this was what was suggested in the chat. And so if we are, I will open it up and see if there is some thoughts, ideas on this. And if not, we can move forward with our 5-5 voting.
Thanks, Mara. Just want to give everyone a second to just read this. And then Blue, go ahead. You read my mind.
I was just curious. I think I had mentioned potentially adding coercion to that last sentence because there are programs that operate at the state, county level that are coercive. That was just my only other suggestion, and it's fine if we've decided to not include it, but I do remember suggesting that.
Thanks, Blue.
I would second adding coercion to the list.
It was looks like it was just added live. Any concerns? Thumbs up. Great. Does anyone want a few more minutes to read this slide? We have time, so if we need to. I'm counting in my head the seconds. Okay, I think we're good. And let me just make sure that there's nothing new in the chat for concerns. Okay, I think we can move. Ashley, would you like to lead us in the vote?
Yes, this is my first Vista 5 vote. So, Mara, if if you could pop in if I start fumbling, please feel free.
So the way that we usually do this, sorry, Ashley, the way that we usually do this is we're gonna do a reminder of this is how it works.
Mhm.
0 is no, 5 is 100%. We don't have to all be at 5. We all just have to be at a 3 or higher. If someone is less than a 3, then we continue talking and then we vote again. But we don't do this individually, so you'll take this down and then so we can see everybody, and then we'll just be like hey, how do we feel about accepting the bylaws with the changes that have just been proposed?
Great. Okay, so let's see, let me pull up the participants. So on a count of 1, 2, 3, please raise your hand and vote on changing the bylaw language. So
Can we pull down the slides?
yes. Okay, that does make it easier to see everybody.
To full. All right. I am not seeing anybody less than a 3. That seems like consensus to me. Heck yeah, new bylaws. Love this for us.
Nice job, everybody. That's great. And huge thanks to Mara for all the behind the scenes work. Thank you. Okay. Kim, you are here, I think. There. Hi, Kim. Nice to see you.
Yeah, Kim is here.
Thanks for being here. So I'm gonna just you have slides, and so we'll pull them up for you.
Okay, perfect.
A second. Oh, is that right, Mara? Are you gonna pull them up?
Yes, we can pull them up. Ashley, do you have them? I can forward them to you. Cool. I will send those to you. And while I am doing that, I have a little intro for Kim. And again, forward. So I just want to remind everybody where we are, like what we're doing, where we're going, and what we're talking about, because we're kind of switching gears here. So when we were talking about our uh, priorities, naloxone came to the top as #1. So we've been working directly on naloxone, and we are going to be continuing to work on naloxone for the foreseeable future. I heard y'all loud and clear when we talked about things that we would be talking about for the rest of the year, and we were like, naloxone is it? Like, this is what we're talking about. So that's what we're doing. So additionally, a reminder that we at ADPC have just done we're in process of finishing a financial analysis in which we asked our partner agencies to share with us their spending from the 23-25 biennium related to substance use and substance use disorder. So we're starting to get some really awesome data. We're wanting to do this again every biennium so that we have like year-over-year spending, some understanding of like where our money is coming from and where it's going. And I wanted to point out that we specifically took naloxone spending and put it in its own category so that we could see which agencies are spending on naloxone and where the spending is going, right? Um, and we also separated it from harm reduction in general. So there is a section for harm reduction, but there is it's a separate spending bucket for naloxone. So we don't have the full picture of spending just yet, and we're starting to see the landscape of what we spend in the continuum. But we have gotten spending reports from a portion of the agencies. The other thing, and the reason why I asked Kim to come and speak to us today, is because I was also able to get data from MCAP from Kim, which is the multi-state purchasing agreement that many of our agencies and many of you purchase through. And so she's going to share with us some more details of MCAP because it's good to have a reiteration. I was telling Mitch this yesterday. I jumped into a meeting with him and Kim and just sat there and listened because it's always good for me to have a reminder of how it works. It's very complicated. And she knows everything about everything. So that's really helpful to have her here. And she's going to share with us some more details of MCAP and some ways that other states or organizations are utilizing the MCAP model. So one clarification before I turn it over. I want to make this clarification here. Save Labs Oregon works through MCAP, but agencies, both state and local, can and do purchase directly through MCAP. So the work we are looking at is not about replicating or changing the way that Save Labs Oregon works. It's about looking at ways to see what is possible outside of Save Labs Oregon, so that they can do their work most efficiently, and we can do the work outside of Save Labs Oregon. So, and then at a certain point, I will show you some of the agencies that have worked through MCAP or Save Labs Oregon, and we can talk about that. So I just want you to have some of these thoughts in your brain, and while Kim is talking, and if there are any questions, please feel free to put them in the chat. And I will introduce Kim.
Thanks, Mara. That's a super helpful overview. Kim, are you ready to share the information with us?
I am. So my name is Kim Hankins. I am the senior healthcare consultant for MCAP. We are a group purchasing organization. We are a state agency out of the state of Minnesota. So we are a government agency, and what our goal is, we do all of the solicitation pieces that keep the contracting and procurement alignment correct for government agencies, whether it's cities, counties, states. We also serve tribes, and nonprofits in some states can participate in MCAP. I live in Oregon. I am a former state of Oregon employee. I used to work for Department of Human Services and Oregon Health Authority, and also Department of Administrative Services. So I spent 18 years in public procurement for the state of Oregon. I know it well, and I've worked with many of you already. So that's just kind of my background and where I come from. MCAP serves all 50 states. So there are 5 other people around the states around the country that do exactly what I do. I serve 7 states in the Pacific Northwest, and my goal is educator, attachment, problem solver, kind of just anything and everything you kind of need me to be, as it relates to finding better solutions for healthcare and purchasing of healthcare. Okay, let's go ahead and go to the next slide. So MCAP, National Group Purchasing Organization, established in 1985 by the state of Minnesota, Office of State Procurement. We are self-funded. Just like most cooperatives or group purchasing organizations, we charge manufacturers an admin fee in order to have access to all of our membership. So it's free for you. Manufacturers actually get charged. So when at the end of the year, because we are self-funded, if there's any money in reserves, we actually share money back with you. So in some cooperatives, it goes back to like Department of Administrative Services. In our case, it goes directly back to each member who is purchasing. And we have two different models that use that. One is medical supplies, and one is our pharmacy wholesaler. So those two programs actually get share back credits every single year. Okay. And as you can see, again, all 50 states are covered. And that membership number, I think, is really low right now. I think we're close to almost 20,000 members currently. Okay. Next slide, please. Our mission really is we are government serving government. We want to make sure that we help stretch that budget funding as far as we possibly can. And provide the best value for pharmaceuticals and healthcare products. That's all we do. We are different than most cooperatives, and we are really niche in healthcare and healthcare only. So again, what sets us apart? Government serving government. We have clinical pharmacists that actually serve on our staff in all classes of trade. So we have one for correctional health. We have one for mental health. We have a clinical pharmacist for public health, and we have a clinical pharmacist for student health. So if anything arises with our memberships that is unique to those classes of trade, they actually have a pharmacist on our staff that they can talk to. We are also member driven. Everything we do is by our membership. Our membership votes on who sits on our board. Our membership also does contract awards once a year at our national member conference. It talks about the wholesaler shareback credit, and those are the two programs that I mentioned briefly before, the pharmaceutical wholesaler and the medical supplies. Okay. All right, next slide. So now we're going to talk about really specifically naloxone pharmacy purchasing options and what is available out in the market and what MCAP members have access to. Next slide. Okay, so we categorize it in two different categories, direct and indirect. I'm going to talk about the direct first because they play actually into the direct side as well. MCAP negotiates contracts directly with manufacturers. So we have Amneal, we have Patagus, we have, let me see, who else do we have? Emergent Biosolutions. So we have agreements with all of those specific vendors. We negotiate a price, and then if they choose to sell directly, members can access them directly. Most of them have a direct and an indirect option. So if they're selling directly, they also have an indirect option. The indirect option is the same price we've negotiated for the direct gets funneled into our pharmacy wholesalers and our medical suppliers. Okay. The difference with the direct manufacturers is we actually, in the state of Oregon, we need what is called a participating addendum or a participating agreement. Department of Administrative Services does that to ensure that we have a relationship with every single vendor directly. When you are getting into a direct manufacturer agreement, it's for a single line product. You can't see anybody else's product. So the price you see there is the price you see there. They also have some specialized data reporting that is available because it's a one-to-one. They can see where all product is going because they know the end ship to locations. Okay, so there's some specialized data reporting that sometimes is available that might not always be available in the direct option. Any questions about the direct option? Okay. Currently, we do not in Oregon have any direct options. Everything is going through the indirect. Okay. Let me talk about the medical supplies. So we have the manufacturer agreements. the pricing for those gets passed down to our medical suppliers. Currently, we have 8 medical suppliers that we do business with in the state of Oregon at the distribution level. In the medical supplies, it's a cost plus model. They have a margin in which they can mark up any direct manufacturer cost. Okay. They carry all product lines for over the counter that we push to them. And they are, and in this arena, it qualifies for that once a year shareback credit. Okay. You can use any medical supplier that you wanted to if you wanted to buy naloxone nasal spray over the counter. If you are wanting to do other methods of naloxone, whether it's ampoules or whether it's pre-filled syringes, because that is still prescription, you would not be able to buy it under the medical supply distributor model. Okay, so then we go to the pharmacy wholesaler model. Again, manufacturers' agreements get pushed down to the pharmacy wholesaler. We have one pharmacy wholesaler in the state of Oregon, and that is Cardinal Health. The reason that we do a one pharmacy model is because we get aggregated discounts based on all or state of Oregon spend. So in this case, it's a cost minus model, which is very different than the medical supplies, which is a cost plus model. Okay. So in the pharmacy wholesaler, all product lines are available, OTC and prescription. So if you wanted Revive, if you wanted Caloxido, all of that is available in addition to all of the different nasal sprays or pre-filled syringes or ampoules. Okay. This one is qualified for 2 discounts, which is the yearly shareback credit that you get directly from MCAP and the upfront discount that you get based on the volume of Oregon spent. Currently, because Oregon spends $6 to $12 million a month, currently that discount is anywhere from around 5% up to 8.5% from what the manufacturer negotiated price is that gets loaded into Cardinal Health. Okay. So the manufacturer negotiated price, say, is $20 per 2-pack for naloxone with X company, then it's an additional, 5 to 8.5% on top of that you would see when you went into Cardinal Health to actually place your order. So you see that discount up front. Any questions about those 2 indirect models? When you're working with Cardinal Health, it also means that if you are a treatment facility, you can also, as long as you have all the licensing and credentialing that is necessary, you can buy any pharmaceutical item. It's not just limited to naloxone because it is a full-scale pharmacy distribution agreement. Okay. All right, next slide. Okay, so next steps. Next slide. So because we share money back with you, we actually have to have every ship to location rostered with MCAP. So there's a membership application. If you are already a member and you just need to add a new ship to location, you just need to contact me and I can do that without any paperwork because it's just a simple address add. Okay. Once your membership account is in place, then I work with you directly to select which vendor you would like to use. Once you select the vendor that you want to use, I work with you and that vendor to get all of your accounts either set up if you've never worked with that vendor before, or if you have an existing account with that vendor, to make sure that account gets transferred over so all of the MCAP contracts get loaded for the correct pricing. And then finally, we're going to fill out any letters of authorization or declaration forms that give you additional discounts. In the correctional setting, for LAIs like Sublocade and Brixadi, there is a deeper discount that the manufacturers are offering. So I work with you to get those letters of participation aligned so that the correct pricing shows up in the Cardinal Health portfolio. Okay. And on some of them, like even if you're not a correctional facility for Brixadi, they have an additional form that needs to be filled out as well. So we have some of that. And then if you're using, like, we have some options for penny a pill for correctional settings for Bupe tablets. Those kinds of things have, you're not going to bill insurance if you're getting it for a penny a pill, right? Types of discounts available. Okay. Any questions for me?
Thank you, Kim. Any questions for Kim?
Naloxone pricing is dropping rapidly right now because you have so many competitors in the market. So I know lots of people are looking at that California negotiated price. We are, even though we're not getting that $19 a 2-pack, by the time we add our volume discount, we are very close to that $19 in Oregon. Yeah.
Haven.
Thank you so much, Kim, for presenting on this. I just want to make sure the only way I've engaged with MCAP is through the clearinghouse and the state funding, but like as a private organization, could we apply to be part of MCAP? Or because you said government to government, so probably not. But I just, so as an NGO.
Yeah. In the state of Oregon, if you are a nonprofit organization, you absolutely can. So we have quite a few nonprofits that are accessing MCAP. The other way that this happens, and this is partly why Save Lives Oregon came to us in the way that they came to us, is because they actually have a lot of for-profit and other organizations that they provide naloxone for. And in order for those entities to have the same pricing that we have, they chose not to give out grants and give the money out directly, because under their parent organization, because they're the ones purchasing, they can have whoever they want to as a child organization, even for profits. So it allows that for profit to get the same pricing. We see this also in some other arenas where an organization has a contract pharmacy, right? So Oregon Prescription Drug Program is a prime example. They have contract pharmacies for a lot of different things, or ADAPT for HIV treatment. They have contract pharmacies. The organization that is tied to MCAP is the government entity. They then can roster their ship to location, which is a for-profit pharmacy, underneath their organizational structure. That for-profit pharmacy can order the drugs that are needed to fulfill the mission of the government entity and get the government pricing. It's just in how we all structure this. So if money is given directly to the organizations, then it sometimes limits the organizations from getting our pricing. If the government entity is adding those organizations under their structure, then those organizations can get the government pricing. Does that help? We can have an offline conversation anytime you want to, and we can walk through, and I can actually, through Secretary of State, pull up what your organization is rostered with Secretary of State with for, and I can walk through that. And then we can talk about what are your granting options? Where are you getting funding from, so that we can triage and see if there's another way that you can access us if you can't directly.
Yeah, Kim, that was kind of where my brain was going as well, and kind of just tagging off of what Haven was saying. As a nonprofit, looking at it the other way, having access to MCAP through the clearinghouse, but that only being one portion of our funding, it might make sense to potentially connect with MCAP with other funding in order to get the benefits of the reduced costs and the bigger system.
Yeah, we're especially in if you're doing the treatment side as well, because we're seeing some really low pricing right now on treatment, whether it's methadone, whether it's bupe tabs, whether it's the LAIs, and I'm having a conversation later today with one of our manufacturers for the LAI to actually do another pricing reduction for those that qualify for Medicaid, because even with Medicaid reimbursement, the cost of the drug is still prohibitive, and entities are losing money if the patient's not going to the pharmacy and bringing in their own prescription. And what we know in this particular with these particular clients is that it's hit and miss if they come back. And so if we have the availability to treat them when they're ready to be treated and not have to walk out the door and come back, then we have more success in starting treatment and continuing treatment. So MCAP is working diligently with our manufacturers to at least be cost neutral with reimbursement.
Go ahead, Annalise.
Kim, we've been talking a lot with you about how to make sure our state agencies are all going through MCAPs. As you know, that's where we're starting. How are we doing with counties? What is your sense of, do all counties know about MCAP? Do we have more work to do there?
We have more work to do. I think counties are a little bit kind of siloed in different departments within the counties too, and who they're using. Does the county have a pharmacy? Some counties do, some counties don't. So if they don't, do they know that they could still use MCAP even if they don't have a pharmacy for some of the clinic options that they have? Benton County is a great example. I work with Nicole Morris all of the time on the pharmacy piece, but her clinic doesn't use us. And her clinic has need to use us, but is not necessarily using us. And they could be saving quite a bit of money, right? And it's just making the connections correctly so that we can talk about what their needs are. Can I help? Am I cheaper? We do all of those cost comparisons. I provide the information back, and they can decide what they want to do. Yeah.
Go ahead, Haven.
Sorry, I have all of the questions all of the time. It's just how I roll in the world. Can you speak to how you compare to like 430B? So like we are an FQ.
Yeah.
Like,
so the 340B pricing.
And is there like intersection? Like this is out of my scope. So I'm just curious.
Yeah. Okay. So 340B is a federally regulated program, right? So and their grants are on different categories. So it's family planning, it's STI, STD. Those are the types of grants that you get. And there's many, many more, right? Through 340B, through HRSA. So HRSA does all of your regulatory. You get designated as a 340B entity. Then you get to pick who you want to use. Pricing is regulated. They set all of the pricing. The difference is you could go out to a Cardinal Health, to a McKesson, to a Henry Schein, to a Amerisource Bergen. You could set up your pharmaceutical accounts. Your pricing is going to be the same across all of those accounts. If you are attached to a group, you're going to get additional discounts. So if you are attached to us, in addition to that 340B pricing that the feds are regulating, you would get that state of Oregon discount of 5 to 8.5% on top of your 340B pricing. There's no prohibition there. So you would just be getting an additional discount. Your spend would go to the state of Oregon volume. And for 340B, yeah, it's at 5 to 8%. But what it does for the rest of Oregon is exponential. For those people who don't qualify for 340B, for those people who do not, who are all taxpayer funded like DOC, you actually help increase the statewide volume, which drives the discounts even lower. Yours is regulated, theirs is not. So the more we have collaboratively in this bucket of spend for the state of Oregon, the more everybody gets discounts and everybody's prices are lowered. So you're just part of the pie, right? Does that help, Haven?
Yeah, I mean, that's kind of, I'm glad I asked. I thought it was a wonky, weird question, but actually,
no, it's a very, and in fact,
one.
For us, 340B is the easiest because it is, the pricing is standard. I don't have to do a pricing comparison. You already know what your pricing is. I'm just going to tell you what your additional discount is. And you just have to determine, are you already getting an additional discount from whoever you're ordering from or not? And could you benefit from ordering from us instead? Easy comparison there. And there is a little bit of that share back credit that comes back, not as much as the non 340B accounts, just because you're already getting a really discounted federal price.
Great question. And that was a super helpful answer, Kim. Thank you.
Yeah.
So I think we're already doing this via the questions and the answers in the presentation that you provided, but just thinking about how we might utilize this information when we're making our larger recommendations for the distribution and best practices. Mara also has a slide that is showing, or has some information showing, which of our current state agencies are purchasing through this program. Mara, is this a good time to show that?
Yeah, so I have a couple of different things. One of them is a slide and another is a graphic. Ashley, could you pull back up the last slide in our slide deck?
Yep, give me one moment.
So I want to bring this back around into, why we're talking about this, right? So we want to make sure that everyone is getting the best price. But when we had talked about this, we wanted to make sure that everybody in the state, if you would like naloxone, you should know where to get it and how to use it, right? So we're starting with our state agencies, and we want to make sure that our state agencies, any of them who would like to be purchasing and or distributing, right, have the ability to do so. So as a reminder, these 14 are the 14 at the top are our 14 partner agencies. These are the ones that in our charter, when the legislature created the ADPC, they said these are the 14 that you are supposed to work with. They're prescribed state agencies. The ones that are bolded, so the Department of Corrections, the Oregon Health Authority, the State Police, the Youth Authority, and an OLCC. Those are ones that, from the data that Kim has sent me, are purchasing through either MCAP or Save Lives Oregon, which is through MCAP. The others at the bottom.
Mara,
yeah.
Real quick, DHS by default of shared services is doing some purchasing through the Oregon Health Authority because we're doing it for all of the state office buildings.
Okay, great.
So, but not all programs are doing it if it's identified for a specific program. So
Yep.
it's a little bit hit and miss there.
Perfect. So that is super helpful. That is super helpful. The also within OHA, there's a lot of things that are shared services as well. So that was a question that I had. So thank you for clarifying that. There's some things that exist in different buildings for OHA, I think, and for different departments within OHA. So there's a bunch of purchasing that happens within OHA. The state police, the Oregon Youth Authority, and OLCC. The ones at the bottom that are also bolded, these are other agencies that showed up on our data list as well. So DAS directly. I think from what I can tell, most of these are existing inside of government buildings. So a lot of this is purchasing for like naloxone inside Portland State Office building or naloxone inside of the Department of Transportation's building. The Department of Transportation, Secretary of State, State Treasury, and OHSU have also done some purchasing through this. So I'd like for you to look at this, and I'd like, after we have gone through, our year of understanding what our agencies do, where we all fit in together, where naloxone fits into all of this, sort of what reactions do you have to this, and what would you like to see in order to make recommendations to either as a general recommendation or like individually? I'd love to get some reactions to this.
What are folks' thoughts for Mara?
I'm guessing we don't have a sense of like how people are using the naloxone they're purchasing, just that they are purchasing through here. Is that correct?
I think so. I think for as a general rule, I believe that is the case. I think that looking at the data, like the spreadsheet, just generally, I've only had this for a week or so. We can tell, if an agency is only ordering, a couple of boxes or a couple of doses, I'm gonna make the assumption that that's for their building rather than for distribution. So, if we're looking, basically, you're right. Yeah, we don't have a good gauge of that.
Haven, are you thinking that would be helpful to have more information related to how they're using?
Yeah, I think what I care about, right? And where the majority of naloxone that gets used, where the biggest health impact in life-saving intervention is like distributing it to people at risk for overdose. Do I anticipate they're using a lot of naloxone in like random state building, right? Like that naloxone is going to sit there, it's going to expire, it's going to get probably still sit there after it's expired until somebody remembers to change it out. And I think that like if we're assessing the ecosystem around naloxone, like yes, knowing I want everyone purchasing at the lowest possible price, that makes sense from like a fiscal responsibility. But I think from an environment, from like a public health intervention standpoint, like I don't really care that much, right? If it's sitting in an office building, I care a lot about are there gaps in it getting out into the community. Again, I don't think we get to find that via like a fiscal analysis necessarily. We can make some inferences on it, but I think it feels important for me to like not lose the why we care about naloxone in the community. And it really is because people who use drugs are the people who are saving lives, and getting it to them across the state is the most important.
I see lots of heads nodding. Does anyone else want to add to what Haven is sharing?
I guess I would just share that really resonates with me as well. I think the
Mhm.
education behind the tool and how is it getting out into the community and the awareness around the fact that it's there is incredibly important. I also look at this list and I see a lot of agencies that we still need to connect with, and just looking forward, what is going to be that plan for getting access? I mean, I look at Department of Veterans Affairs, especially. And I do believe we've had a lot of progress in that area in the state of Oregon. So trying to understand more of the disconnect around some of these agencies and how do we bridge those gaps and those collaborations.
Naomi, go ahead.
Yeah, I agree. I mean, it would be wonderful if we could have some kind of mapping of how things are getting funded and the pathway that they reach different entities so we can really see the gaps. I think one of the great things about how naloxone is distributed right now is it could be from a funder and it's given to an organization, which then gives it to another organization. So eventually it can get to folks who most need it. But sometimes that's really hard to map out. But I think at least most of the folks we're working with in Washington County, we're mapping not only what their distribution to organizations are, but also their utilization. And so those could be two things that we could look at to maybe get more information.
So it sounds like a really detailed evaluation of each of these entities and who they are distributing. Is it actually getting used? Just some basic information and questions for them. Does that sound right?
I love also how someone's mentioned education, because I think we have really high utilization in some of these areas, but it's not necessarily the best utilization. And I think that's just a lack of education and maybe over naloxone use. So that's another thing to consider in this.
Thanks, Naomi. An ecological map of all things harm reduction. That's great. Mara, do you feel like is this helpful in terms of like building out the next steps?
Yeah, I definitely think this is helpful. I do have one more thing that I think that we might have some reaction to if people feel like they're able to
Yeah, let's see
not move
something
on.
that has a reaction attached to it. That sounds great.
Okay,
Let's look.
let's see. So this is um a very basic graph of some of the data from MCAP. So I want to, put some caveats in here. This is was very quick. This was like manually done by me and Will. So there's definitely some rounding that's going on here. But I just sort of want to explain this a little bit. So we looked at the 24, 25, the biennium from beginning of 24 to end of 25. And about 34,000 units of naloxone were purchased within the state. 65% of that was purchased through Save Lives Oregon. 35% of that was directly through MCAP. And then we sort of broke it down within those units. About 10% was purchased by state agencies, about 35% local public health authorities. And then everything else we haven't gotten down to the nitty gritty yet. So, but we classified this as corrections, police and fire, the cities, things that are youth specific, community-based organizations. So this is sort of like a breakdown, very basic, very preliminary of what we were looking like in within those years in terms of purchasing naloxone. What I'm hearing is that we care less about this and more about what happened to it after it got purchased.
folks' reactions to that last statement from Mara. We care about this, but even more about what they're doing after they receive it.
I think it is helpful seeing who initially receives it, because I think that tells us what the pathway is. And if they're being that effective in receiving supplies, I wouldn't want to just shut it down, but I wonder if we can use it to better get resources to folks who need it, if that makes sense. So I hate to shut down a pathway. I don't know if that's necessarily what you're saying. That's my kind of blunt kind of feedback, but I think something's working well and we could use that to educate our steps.
Love that.
Yeah. So building upon what's already working. They're receiving the funding, they're receiving the naloxone, but what's happening next?
Well, and I would just say as we move forward and bringing on the agencies that aren't already distributing naloxone, taking into account those that have and are successful, and making sure that education is passed on in the best way we can.
Thank you.
I
The
also,
nice thing
oh, go ahead.
The nice thing too about the way Save Lives Oregon has structured theirs is because they are the build to and they have every ship to and everything's going directly instead of it going to one location to Save Lives Oregon and then Save Lives Oregon pushing it out. It also means that every manufacturer can do an overlay of where exactly product is going to by zip code. So so you know where penetration is across the state. When you have a direct ship to model or a centralized location, manufacturers cannot give you that extra data. That extra data has to be pulled directly from the distribution point at that central location. So Oregon has set it up to where it's easier to pull data and actually see penetration. Where do we have naloxone, but we're still having higher overdoses? Maybe it's not because we don't have naloxone there. Maybe there's another reason that is happening in that location, and then it's easier to quickly identify.
That's helpful information. So it's another layer that's already built into the data that you have, which helps to tell a little bit more of the story. And Jenna is making a great point in the chat around where we're not getting naloxone is also something to be thinking about. Right. So it's like developing the next layer of this like ecosystem map of as to where the supplies are going after they're received by our main agencies, how they're utilizing them. And then from there, like identifying the interventions in terms of like education or whatever the next steps are for our plan. Does that kind of capture some of the, Mara, is that what you're hearing?
Yeah, I think this is super helpful for me to understand like what the next steps are. I know that this is like super incredibly slow, and I know that this work has been that this is like the work that y'all have been doing for ever and always, and like I really appreciate being, brought in so that we can try and make this, as good as it can be. And just know that like I know that this is going really slow and this feels like a snail's pace. But thank you for clarifying at every level.
Can I just jump in and say, can you go back to that other slide? The graph slide? If possible. I'm really curious, like I love that 65% is coming from Save Lives Oregon, and I'm also pretty nervous about that funding being maintained going into the future. So like understanding who is purchasing naloxone through MCAP on their own as opposed to under the Save Lives Oregon feels like something, like as someone on the Save Lives Oregon like steering committee, like if we have to start thinking about who can stay on Save Lives Oregon just based on funding, that this is not the case currently, but also I am terrified of our current government and our current financial situation as a state, as a counties, whatever. Like thinking through what types of organizations could be purchasing through MCAP versus through the clearinghouse feels like something that would be important to like think through. I would be curious if we could break out the second set of this slide so that 55% is everything that's not a state agency or a local health department. Like what proportion of those are, like, I'm guessing the like local health departments they're distributing it or they're sitting on it, right? And so like how much are going direct to people who are distributing naloxone versus having it for themselves feels like an important piece of this puzzle, right? Like 10% for state agencies, that seems really low with the compared to what like local health departments may be purchasing, things like that. So I don't know, again, I don't know how we dig into some of that. I do also do feel like there's a difference between uniformed responders having naloxone for an emergency versus someone who is giving it to people who use drugs. And like, not to say that if we are in a scarcity scenario, I want all the naloxone going to people who use drugs. If we're not in a scarcity scenario, then everyone else can have it too, right? But I'm really concerned that we are moving towards a scarcity scenario. And I like having that breakdown feels important. I'm rambling. I'm sorry.
You're not rambling. It's great, Haven. It's super helpful. And I'm assuming it's helping Mara to think through like what data does she have? How could she slice it to get those different views? And I also want to just acknowledge that it really links to the comments that I'm seeing in the chat around like continuing to map in some ways how much of it reaches an expiration date, how is it exposed, what are they doing once it's expired. Sorry, I was putting disposed and expired together. But I think there's like this mapping all the way to like who's holding it at the very end at the expiration. Maybe we can think about it that way. Is it on a shelf? Is it in someone's hands? Has someone used it? So different ways I think of mapping this out.
One of the new programs MCAP does have, and we just negotiated this with one of our manufacturers, is from this point on, any expired pharmaceutical that is purchased from one of the manufacturers, it's a one-to-one expired replacement moving forward. So in a couple years, when product starts expiring, some of it has a 30 to 36 month to a 48-month shelf life. So we're a little bit down the road on that, but they are going to be doing a one-to-one replacement of expired product.
Luke, go ahead. Thank you, Kim.
I don't know if this is actually the right place to bring this in, and I know it was mentioned before, but like I think if we can get, especially since the expired naloxone trade-in won't happen for a couple of years, based on what I just heard, giving some clarifications. I know if there's a pharmacy attached, like there are different rules about expired medication, but like making sure that organizations know, like I mentioned, a local organization revealed they had over 3,000 expired doses of naloxone that they didn't think they could give out. I don't know. I don't know like what ended up happening with that, but I said, well, like we can distribute it if you can't. Like we definitely want to, we don't want to see that going in the trash. But like I think there are some organizations that may have currently, expired naloxone that are very unclear on whether they can distribute it. And I think like being able to communicate that could be really helpful until we get to that place where people can exchange their expired naloxone.
Thank you, Blue. I know that Mara has that down in terms of like really clear guidance around the expiration. So that's very helpful to bring up again. Thank you. Eric, I see your hand.
Yeah, I mean, I have a relatively limited worldview, since I kind of work at like the ground level. But what I've seen with just people I've worked with and agencies I've connected with is I feel like some of the homeless services, the shelter programs do a really good job of getting it out to the people who would need it the most. And like agencies like ours who primarily do medically assisted treatment do pretty good since we actively serve opiate, affected people. But the area that I have seen where maybe there could be more support would be like primary care. I mean, and I don't know if they would have a way. Like, I see the thing is like it's even hard for us to give it away at the medically assisted treatment office because people don't want it. They're like scared to take it. But there are some like tools that I've been able to use over the years to like sort of negotiate that with participants. And I just wonder how more like for the normie, participant who goes to primary care who maybe has a severe opiate thing, but would never think that that would be something they would need, but actually could actually need it at some point. I don't know what the educational piece would be for the primary care facilities, but I know that that's just a point of contact where especially a lot of earlier in their progression opiate affected people come from.
Yep, that's great, Eric. So the different like educational needs for based upon setting, making sure we're capturing all of them. That's great. Thank you. Anyone else? Yep, Kevin just bringing up that there's a perception of risk and people deal with around talking about naloxone. That's yep, yes. And then Kim, just making sure that you saw a request to go to maybe connect with someone afterwards, Serafina, to talk more about your program. So we'll make sure that
Okay.
your contact information is shared if that's okay.
Yeah, no, perfect.
Great, thank you. You can put it in the chat or we can put it with the notes when we send them out. Anything else before we move to public comment? So lots of requests around the mapping, highlighting a huge need for education, and lots of discussion needed and information needed around or clarity needed around expired naloxone and next steps. Mara, do you have any last minute questions before we?
No, I think this is incredibly helpful. Thank you all so much. When I said like what I'm hoping to get from you is your reactions, like this is exactly what I was hoping for. So those of you who were, kneecapping your sentences, you don't have to do that. This is exactly what I was hoping to get from you. I think it's really helpful for me to hear both like your reactions from like the people who, those of you who are doing like this like direct service, boots on the ground level work, and those people who are doing like more upstream policy level work. Like that is really helpful for me to separate the like upstream and the downstream. My background's in prevention, so if you'll forgive my colloquialisms, it's really helpful for me to be able to separate those things. And I'm seeing like a lot of really great connections with like this mapping of like, oh, here's what we're doing with Save Lives Oregon. Here's where Save Lives Oregon can be helpful in this. Here's where we can be helpful to them. Here's where we can be helpful to the local public health authority. Here's where we can provide recommendations. I'm seeing lots of connecting points here. So thank you so much. Thank you. I really appreciate it.
Okay, good. Yeah, it's really unique. I'll just reflect to be able to have kind of the higher level organizational viewpoint and the actual nitty gritty. This is what truly happens with naloxone at one space at one time. So, and this is a really great conversation and meeting. Thanks to everybody. And Kim, thank you so much for your presentation. We're down to, I need to transition to public comment because I'm seeing it's 11:56.
Thank you for having me.
So we'll transition to public comment. Is there any questions or comments from the public?
And Stacy, I did not receive any written public comment.
Okay, thanks, Ashley. Just gonna give it one more beat. Okay. Fantastic meeting. Thank you everyone for the wonderful conversation. Mara, thank you for prepping us so well. And Kim, thank you for joining us today. Really great information. Thank you for the partnership. Our next meeting is May 26th. We will see you then, and of course, over email or phone conversations as needed in between now and then. Have a great day. And it's, again, good to see everyone, and thank you.